The lecture for cardiology that I'm going to be doing today is not supposed to be EKGs, because we could sit here literally all day and go over EKGs. That's kind of not the purpose of this. And the reason why is because what's on a test, especially for like the National Registry, and talking about, is it just going to be EKGs? Well, no, you have to be able to split up cardiology with the National Registry into several different categories. Now, the first category that we need to talk about, is it going to be pathophysiology? And what I mean by pathophysiology, what kind of diseases or what kind of problems is that patient experiencing that could be cardiac in relation? So with regards to that, we got to look at, or we got to think about the algorithms, right? With ACLS and with PALS, do we have bradycardia? Do we have tachycardia? Do we have cardiac arrest? And then also don't forget ROSC is a big algorithm when we talk about the pathophys side of cardiology. With the National Registry, they will ask you algorithm questions. So if you do not know the algorithms or you're unsure about some of the algorithm stuff, please make sure you review it. Another thing that we need to determine is anatomy. So whenever I say that we have to split cardiology into several different lanes, again, first one's pathophys. Is it cardiac relation? Is it some sort of disease? Are we talking about an aortic aneurysm? Are we talking about pericardial tamponade? Are we talking about pericarditis? Are we talking about anything like heart failure? These are all different diseases that the heart has that we need to consider when taking a test. Not only do you need to know signs and symptoms, but you need to know a little bit about the physiology of what's going on and also how we're going to go ahead and treat that. The last one that you have to know is EKGs. You will be tested on all three of those aspects. Now, I know here it says know the pharmacology. That's going to always be in relation to diseases and also technically EKGs. If there are certain EKGs or abnormalities that we treat with meds, you have to know why we treat with that med, what's the dose of that medication, and we'll talk a little bit about that today. I'm not trying to make this too much of a pharmacology type review, but I can't talk about treating cardiology or cardiac issues without discussing a little bit of pharmacology. And of course, as always, I will answer any questions that you guys have. Starting with the ANS, the autonomic nervous system, we need to know that there's two different sides of this, right? Remember, it's autonomic, it's automatic. This is the sympathetic and the parasympathetic nervous system. Talking about the sympathetic nervous system, the couple things that you have to know about the sympathetic nervous system. First, will increase what? Cardiac output. It's going to increase rate. It's going to increase contractility. The second thing that you need to know about the autonomic nervous system when it comes to sympathetic is that it utilizes a neurotransmitter. I would write that down, a neurotransmitter or a hormone. It's both technically. And that neurotransmitter is called norepinephrine. It says sympathetic nerves are regulated primarily by norepinephrine. And by doing so, it's going to increase, again, rate and mechanical contractility. Jumping into the parasympathetic. If I told you that the sympathetic nervous system increases contractility and increases the heart rate, and then I said that there's a parasympathetic nervous system that does the opposite, obviously this is going to slow down the rate. Now there's a neurotransmitter that was used for the sympathetic nervous system. You need to know that the neurotransmitter that gets utilized in the parasympathetic nervous system, and that is acetylcholine. Okay, acetylcholine affects a receptor site called a muscarinic receptor. And what it does is it will lower the heart's rate by using a vagal stimulus. It says parasympathetic nerve fibers supply the SA node, atrial muscle, and AV junction. So if you know anything about the parasympathetic nervous system, you know that it affects from the AV node up. People ask me like, hey, Mike, if I have a VTAC on the monitor, should a vagal maneuver be appropriate to treat a VTAC? Can we consider it? Sure. Especially if you're thinking like, hey, man, it's monomorphic. I know I'm not talking EKGs, but especially if you're considering it to be monomorphic, you can consider SVT with an aberrancy. But should a vagal maneuver work with a ventricular rate? And the answer is no. Why? Because again, the parasympathetic nervous system affects, when we talk about the heart, AV and up. That's just a rule. So again, this is like an anatomy type question. Which neurotransmitter is regulated by the nervous system? With parasympathetic nervous system, it is acetylcholine. Talking about actually having a vagal maneuver performed on a patient, there's multiple different ways to do it. In the hospital setting, they do something called a carotid massage, typically not practiced by EMS. There's a couple reasons why it's not practiced. One big one is if done incorrectly and putting too much pressure on the carotid sinus, you can actually reduce the amount of blood flow that goes to the brain. Probably the more popular one is asking your patient to bear down. That one's kind of here, distension of the hollow organ. You ask a patient to bear down and they'll perform a vagal maneuver. Remember, by performing this vagal maneuver, they stimulate the vagus nerve, the 10th cranial nerve. And by doing so, it sends acetylcholine, again, to the patient's heart, to that area between the AV and the SA node, and it'll lower the rate. Another one, obviously a popular one, is having somebody blow through like a 10 cc syringe. So there's a lot of different vagal maneuvers out there. Remember, we're using vagal maneuvers typically to slow down rate. And we're going to talk a little bit about that when we get to tachycardia. Let's go ahead and take a look at this conduction system. The conduction system is something that you need to know about and how it works as a student, not only just to get through paramedic school, but also to take the national registry. There's so many different types of questions that they can ask regarding the conduction system. Understanding the conduction system makes it a lot easier also to read EKGs. And you can tell what's going on in an EKG if you understand the conduction system. Starting at the SA node, this is my primary pacemaker. I'm not going to say everybody, but most people, their primary pacemaker starts in the SA node. If your primary pacemaker, the start of conduction or the start of depolarization, which we're going to get into that terminology, starts here in the SA node, your intrinsic rate or your heart rate, the normal heart rate for the SA node is anywhere between 60 to 100. I'll repeat that. Normal heart rate for the SA node is 60 to 100. Once the SA node fires, and if you look at this diagram, you can see these pathways that are outlined in orange. Those pathways are showing you which way the conduction system's going. So for example, we have a fire here in my SA node. We see that it's outlined in orange and it's going all the way over here to the actual other side of the atrium. Even though it starts in the right atrium, it still conducts over to the left atrium as well. So when the atrium contracts or depolarizes, both sides of the atrium contract together. By doing so, it pushes blood and it makes those heart chambers tighten up. That blood drops through their respective valves into the ventricles. As you can see, there's no real conduction down here inside of the chamber, but it's in the muscle tissue that is surrounding the heart's chambers. So we go ahead and take a look at this. We have a bundle of His right after the AV node. Remember, this AV node is here to cause a pause. Once that pause occurs, it allows for those ventricles to fill up with blood. Then the conduction or the electrical impulse shoots through the bundle of His and then through the right and left bundle branches. Once it goes through ththose bundle branches, it goes into the Purkinje fibers and causes an electrical contraction. And that is what actually causes blood to be pushed out of the ventricles. I'm not really going to go through blood flow because that's very EMT, but you need to know the EMT stuff also, like blood flow. It just takes a little bit more time. What I recommend always with blood flow is watch a YouTube video that actually has some sort of animation showing you that the blood enters deoxygenated into the right atrium, dropping through tricuspid valve and watching it go through its stages. If you don't have any good notes on blood flow, I highly recommend to do so because they will ask you questions. All right, depolarization, a terminology that you have to know. Terminology of depolarization and repolarization. Again, this is utilized in EKGs as well. For example, SA node depolarization or P wave and different things of that sort. Depolarization, by definition, is when the cell receives a stimulus from conduction. Now, there's certain things that happen when we say a cardiac cell is actually getting ready to depolarize, something that happens with their ions. And let's take a look. Permeability, which means that it allows fluids and it allows these ions to come in and out of the cell. permeability of the cell wall changes to allow sodium ions in. So if you remember, we have 3 different ions when we talk about the cardiac cycle: sodium, potassium, and calcium. So let's take a look at this. When the cell depolarizes, if you're taking notes, which I highly recommend you do, you must write this down. With depolarization, sodium enters the cell. Calcium also enters the cell. Because of these 2 ions, this causes a mechanical contraction. Depolarization causes a contraction when sodium and calcium enter the cell. Whenever we talk repolarization, what are we talking about with repolarization? Basically, the cell, it has to get ready or charged up so it can depolarize again. For repolarization to happen, those sodium and calcium channels need to close off. Potassium channels now open, and sodium ions get pumped out and potassium comes in. So potassium inside the cell, sodium and calcium out, repolarization. Very easy for a test question to say during a cardiac cycle, what occurs when potassium enters the cell? This is a very basic type of cardiology anatomy question. And the answer would obviously be repolarization. Jumping a little bit away from some anatomy stuff, don't worry, we're going to be chiming in and back and forth on some of that anatomy stuff. If you have any questions about anything that I talked about so far, just hit me up. What is hypertension? By definition, 140/90 consistently. So somebody who's constantly over 140/90 while at rest. If you've ever done any sort of stress exam, putting the 12 lead on and running on a treadmill, they'll also check your blood pressure, and they want to see how high your blood pressure goes under stress. Now, you're at stress blood pressure versus your at rest blood pressure should be way different. If your at rest blood pressure is over 140/90, you're clinically hypertensive. Most cases result from advanced atherosclerosis or arteriosclerosis, right? When we actually have a plaque buildup inside of the arteries. Having hypertension or prolonged hypertension puts you at a greater risk for strokes, heart attack, heart failure, and even kidney failure. So a lot of problems that we see, obviously, in EMS, a lot of problems that could have probably reduced for that patient, or the patient could have fixed earlier on in their life if they would have realized that they had the hypertension and possibly treated it early. Again, some people with hypertension, it's just the roll of the dice, right? There's some people that are really good health and they just have hypertension because it's just in their genetics. Some people, it's based on the foods and the lifestyle that they have. For a lot of people, it's easily treated. There's a lot of medications out there, statins, prills, beta blockers, a lot of different ways to treat hypertension are often seen. With regards to hypertension, because the first thing that a lot of people want to think about when they hear hypertension is, are we treating it or not? Once you get hired somewhere, you'll probably have some sort of hypertensive emergency protocol that you're going to be following. And if we have somebody that has blood pressure greater than 140/90, it's not a problem. A lot of adults, and especially in the elderly, have over 140/90 all the time. It's not a problem. What becomes a problem if it gets too high, and the patient starts to have symptoms. So let's take a look at this. This is called hypertensive encephalopathy, or an acute hypertensive crisis. One's blood pressure must exceed 200/130. This is straight out of the textbook. This is part of the national. 200/130 is considered a hypertensive crisis. Any mean arterial pressure that exceeds 150, fluid will leak through the blood-brain barrier, causing ICP with a MAP greater than 150. So you can already see the problems what hypertension could cause. If somebody has hypertension, we now will step in as EMS to lower blood pressures. Can anyone give me a medication that comes to mind that you would utilize to treat a blood pressure? Interesting that nitroglycerin does get brought up, because nitroglycerin is a vasodilator. Your body has something called baroreceptors, and that's with a B. Baroreceptors are located throughout your body circulatory system, and what it checks for is barometric pressures. When it finds that your pressure is really high, what it does is it causes vasodilation. So typically when you see somebody who has a high blood pressure, What do you notice about their face? Have you ever seen somebody who has really red skin or flushed skin and they have hypertension? Well, what's happening is, their body realizes, hey, dude, we got high blood pressure. Let's go ahead and fix it. So your body's compensatory mechanism is to dilate blood vessels and try to lower down the blood pressure. With that being said, typically, vasodilators are not used to lower down blood pressures when somebody has hypertension. We need to lower the amount of work that the heart's doing. So I saw a couple good answers here. David put labetalol, which is a beta blocker. We know it's a beta blocker because of olol, right? The suffix. And Chris says an ACE inhibitor like lisinopril. Prils and beta blockers are often used to treat hypertension. Good medications, because what they do to the heart is reduce the amount of strength that these hearts are actually contracting. And by reducing the heart's workload, it lowers the blood pressure. Let's take a look at labetalol. Moderate to severe hypertension. Again, this is straight out of the book. Moderate to severe hypertension, contraindication, bronchoasthma, heart failure, cardiogenic shock, second or third degree heart blocks, of course, bradycardia. If you give something like labetalol or you give a beta blocker to somebody whose heart is already really weak, you'll potentially kill that person. So please do not give any sort of beta blocker to somebody who already has a weak heart. The adult dose, 10 milligrams IV push over 1 to 2 minutes every 10 minutes. Look at that. You can give it 15 times every 10 minutes. So typically, once a patient, for example, goes into I don't want to say out of left field, but if the patient's having a stroke, for example, and they have a really high blood pressure, they go to the hospital, they go to the CT. The CT finds out if they have a bleed or not. If the patient does not have a bleed, they might decide, hey, let's start giving 10 milligram increments of labetalol to bring this person out of a hypertensive crisis and try to get their blood pressure normalized. The doctor will usually have some sort of range in which he or she wants to see, but that's what labetalol does. You give it in small increments and you're constantly monitoring that patient's blood pressure. What does it do? Blood pressure reduced without reflex tachycardia, total peripheral resistance reduced without significant alteration in the cardiac output. Problem with labetalol is you don't want to give too much. You don't want to affect the patient's cardiac output, right? That's why we give it in small increments so we can continuously monitor them and make sure their rate doesn't get too slow or their blood pressure doesn't drop dramatically or anything of that sort. Acute Coronary Syndrome, ACS, angina or MI. So the first thing we need to consider whenever we hear the word angina, right, we need to think chest pain. Is it stable or is it unstable? For me to say that somebody has stable, that means that the patient has chest pain. That gets better when the patient stops whatever they're doing. For example, you get Mr. Smith who's mowing the lawn, and Mr. Smith gets crushing chest pain while he mows the lawn. So he goes inside, sits down, has a glass of water, and hangs out, and the chest pain goes away. We call this stable angina. Unstable angina is seen when that chest pain doesn't go away, or when the chest pain occurs at rest. If you ever go to a patient's house or you have a patient who tells you that they were awakened from their sleep with chest pain, this is considered unstable angina. Unstable angina is much worse than stable angina for obvious reasons. Now, what you're seeing here on this photo, like the Levine sign, a lot of you are going to have test questions about the Levine sign. Remember, Levine sign is typically when somebody has a closed fist and it's on their chest. Oh, I got chest pain. That's known as the Levine sign. A couple different ways that blood flow might be reduced to the heart whenever we're talking ACS and saying that, hey man, someone's having an acute myocardial infarction. Could it be from atherosclerosis? Sure, saying that the patient has plaque buildup inside of their arteries. But what is Prinzmetal angina? Prinzmetal angina is when we're talking about something else causing those blood vessels that are within the heart to constrict. I'm going to give you an example. And this is real, man. I'm sure you guys have seen these super cold baths that people do, especially in Northern Europe and things of that sort. Did you know that there have been cases of people jumping into either really cold water and they actually have a heart attack? Now, this is called a Prinzmetal Angina. When those coronary blood vessels that are surrounding the heart tighten up, and they tighten up so much that it actually limits the amount of blood that gets to the heart, and then that person actually has an acute myocardial infarction because of their own environment. They get into an environment that causes them to spaz, and the blood vessels spasm up, and they actually have a heart attack. Pretty wild. That's Prinzmetal angina. STEMI versus non-STEMI. I think we all know what STEMI means by now. ST, elevation, myocardial infarction. STEMI means injury. If you ever see a test question talking about ST segment elevation, remember, it means injury to the heart tissue itself. Whenever you see non-STEMI or NSTEMI, they're talking about ischemia, okay? A non-STEMI typically is ST segment depression, okay? ST segment depression versus ST segment elevation. Remember, elevation injury, ST segment depression, ischemia. And if we remember what ischemia means, lack of oxygen. So that there's lack of oxygen that gets to the heart that causes chest pain. Pathological Q waves is, and I know I said I'm not going to talk EKGs, but the fact that we're talking about acute myocardial infarction, have to bring this up just as a reminder. It's one of the two, right? First one, we get a Q wave, remember at the base of the start of our QRS complex, that is greater than 1/3 the height, the amplitude of that QRS complex. So if I have a positive deflection on my QRS complex and I have a negative Q wave, which is normal, but that negative Q wave is greater than or equal to 1/3 the height of that QRS complex, you're looking at what's known as a pathological Q wave. Another way to determine a pathological Q wave is to see the width or the duration of a Q wave. The Q wave must be wider than 0.04 seconds, bigger than one little block, and it's just a much wider looking Q wave. That's classic for pathological Q wave. Now, of course, you might be wondering, well, Mike, what the hell is a pathological Q wave? All that means is that the patient has history of infarction. So they have tissue that's inside of their heart that is dead from a previous heart attack. Maybe they didn't get a stent in time. Maybe they had a heart attack and it was just a really bad one and they ended up recovering. We can still see previous damage on their EKG if they had a previous heart attack by seeing pathological Q waves. Where does the pain come from? We talked about lack of blood flow. Your body is trying to talk to you. If you have chest pain, your body is saying that your heart is not receiving as much blood as it needs. And to warn you, your body is going to show signs of pain. It's basically inflicting pain on you so you know that your heart needs oxygen. That's it. Those pain receptors start going off saying that, hey, we need oxygen. Does the pain change with deep breathing or movement? What do you guys think? If my patient is having an acute coronary syndrome or acute myocardial infarction, if they take a deep breath, should it make the pain worse? Should it make the pain better? If my patient moves around, should the pain get worse or should the pain stay constant? So this is an interesting part about acute coronary syndrome and myocardial infarctions that we have to know. If my patient moves or my patient takes a deep breath or you touch their chest, the pain should always remain constant. It shouldn't get worse. It shouldn't get better. The pain remains the same. The reason why we do little tests like this and we say, hey, take a deep breath, or hey, I'm going to push on your chest. Does this hurt anymore? Or hey, what makes the pain feel better or worse? We ask questions like this to try to determine what's going on. If my patient says it hurts when I take a deep breath. Oh, all right. Now we're talking about pleuritic chest pain. Pleuritic chest pain is sometimes seen in like pneumothorax, could be a lung contusion, Could be a lot of other things. But yeah, we have to ask these questions. And remember, if they're having an acute coronary syndrome or a myocardial infarction, the pain should remain constant. Moving or taking deep breaths should not make a difference. How should they present? Now, typically when patients present with an acute myocardial infarction, they're pale and clammy. Not always pale and clammy, but clammy is one of my symptoms that I see a lot, and it makes a big difference. And I'm going to tell you a quick story. One time I had a patient who was the mother of a doctor, an ER doctor. She told us when we got there, my son's an ER doctor. He knows that I'm having chest pain, whatever. He wants to talk to you guys on the phone. So, hey, what's going on? My name's Mike, whatever. And he said, hey, I know you're with my mom. Can you please hook up a 12 lead to her? And can you let me know if she's sweating right now? And I said, yeah, she's definitely clammy. And immediately he was just like, okay, start heading off to the cardiac facility and let me know what you see on the 12 lead. Like he was immediately, just from hearing that she's sweaty, the doctor already knew what was going on. And I always tell my mom too, if all of a sudden, if you're just hanging out at rest and you start to get like sweaty and clammy out of nowhere, no reason, you need to take that as a sign. And it's not a good sign. Something's wrong, unless it's obviously hot as shit in your house. Maybe that might be normal. But if it is not, and it's a normal damn day, you're in the AC and you just start sweating all of a sudden, abnormal, right? And with that, we got to talk about atypical chest pain. 3 patients. If you're taking notes right now, you need to know this. 3 patients will have atypical chest pain. Atypical chest pain number 1, females. You have no idea how often I come across women that are signal 7, they're dead on arrival, and they have the gas X, the Pepsid, whatever, by their bed. So by just looking at that, I already know what happened, right? They were having an MI. They thought they had indigestion because they feel heartburn, or they get acid reflux, or they're just having abdominal pain. So they go lay down in bed, they start popping Tums or other antacids or whatever the case might be, and they just wait. Believe me or not, I see this often. That is atypical chest pain number 1. Atypical chest pain number 2, diabetics. Patients who have diabetes are prone to have way different symptoms. They might not experience any sort of chest pain. They can have lower back pain, they can have abdominal pain, but diabetics are known to not have a regular chest pain. Last, 3rd patient is the elderly, geriatric populations. Some geriatric populations, they won't complain of pain at all. You'll show up and they feel weak and they look like shit, right? They're diaphoretic, whatever the case is. We get to put them on a 12 lead and we see that they're having an MI. Or they might just have nausea. They vomit. They tell you, oh, it must have been what I ate. And you're like, oh, what'd you eat? And then we're putting them on a 12 lead and then there it is. We're having an MI. So don't always think because you hear a heart attack or because you hear myocardial infarction or you're reading a test that they're talking about chest pain when it comes to acute coronary syndrome. Do not expect that. 12 lead changes. Now, I know I said I'm not going to go over 12 leads. I'm not going to talk about EKGs, but you have to know what is causing your 12 lead change. What's going on here, right? We got a patient who's having an acute myocardial infarction. What is happening and why is that patient experiencing the symptoms that they're experiencing? Now, talking about a right coronary artery, also known as the RCA, you have to know this. Please write down what is supplied by the RCA. Right coronary artery, which on this diagram is that one over here on the left side of your screen. The right coronary artery supplies the right atrium, shocking, right ventricle, part of the left ventricle, okay, which you see this thing like wraps a little bit around the heart at the bottom, and portions of the conduction system. And that's it. Right atrium, right ventricle, part of the left ventricle, and conduction system. Now, the larger of the two. This is the largest of the myocardial coronary blood vessels. Divides into the left anterior descending, okay, the LAD, and the circumflex. So it branches off into 2 other coronary arteries. What it feeds in the heart is the left ventricle and the septum. The left ventricle is the big one, right? So if you have damage to the left ventricle, then obviously that heart's not going to be able to pump throughout systemic circulation. That is a 100% anatomy question. I can almost guarantee that everybody in this little group here is going to have some sort of question off of those two slides on their national registry. And that's based off of coronary arteries. What's the goal here? We're treating a patient with chest pain. We've talked about what causes angina, what causes unstable, or what is unstable versus stable. So if you know that lack of oxygen is what causes the pain, what is the goal? The goal is to get more oxygenated blood to the heart. Period. That's the goal for treatment. Now, if you were ever taught MONA, MONA stands for morphine, oxygen, nitro, and aspirin. Those are the four treatments that have always been talked about when it comes to chest pain. Is it still talked about? First off, yes, it's still brought up. Now, one thing that's interesting about MONA is oxygen. Prior, I can't even put a year on it, but several years back, we used to give every patient with chest pain oxygen. It was just like a standard. Oh, you got chest pain? We would start with oxygen. Remember, BLS before ALS, right? We would always start with oxygen. We no longer do that. Understand this. Oxygen acts as a vasoconstrictor. And if you vasoconstrict, what are you doing to the heart? Causing less oxygen to get there. Even though you're giving them oxygen, you can actually limit the amount of oxygen that you get to the heart because you're giving the patient oxygen. With that being said, should we be giving patients with chest pain oxygen? Only if they're hypoxic. It's gotten so extreme that even in the American Heart Association, we're only giving oxygen, just like with strokes, if the patient's SpO2 is less than 92. But as long as you know, we're only giving the patient oxygen if they are hypoxic, not just because they have chest pain. Next, aspirin. Aspirin is a medication that we give called a platelet aggregator. What it does is it stops platelets from trying to clump up on each other. It's not a blood thinner, right? It's not an antiplatelet, just makes them not stick as well on top of each other. Because remember, platelets, they crash into each other, then fibrin gets included, and then it creates this clot. But if your patient is on aspirin, those clots aren't readily made as easy. That's the whole purpose behind aspirin. Now, it's interesting when we talk about the dose. One thing that I want to tell you about the dose is every single baby aspirin, like little pill that you're holding in your hand, is 81 milligrams. We give 2 to 4 baby aspirin to our patient on a test. They are not trying to trick you. If they say 160 milligrams to 325 milligrams, the test is not trying to trick you. They're not trying to say, oh, we put the wrong dose on there. Let's see if the student No, how these tests are written, 160 to 325 is considered a normal dose. Even though I just told you each tablet is 81 milligrams, so technically it's 324 for 4. 325 is acceptable in the national standards. Most tests that you're going to look at, they will say 325 milligrams. Do not think that the test is trying to give you a wrong dose, because that is the right dose per testing when you go and take the test. So just understand that. 160 to 325 is fine. Next, nitroglycerin. Nitroglycerin is 0.4 milligrams, and that is per spray. Each spray goes under your tongue. We have to wait 3 to 5 minutes before we can give an additional spray. Per national standards, and this is the most updated, is we are still only giving up to 1.2 milligrams. That is a standard. Once you get hired somewhere, or some of you that are hired, your protocols might dictate that you can give more. That's fine. That's what your medical direction allows you to do. But understand, as of right now, the standard for the National Registry is up to 1.2 milligrams. 3 sprays. Can we consider nitro paste? The answer is yes. If you carry nitroglycerin paste, we give that over the skin, right? Transdermal, and we do it over the patient's chest. Typically, you give 1 inch of paste, but nitro paste is commonly seen and commonly used for chest pain protocols. It's the same concept of giving somebody nitro. except now there's two different routes in which that nitroglycerin is getting into the patient. Morphine, starting at 2 to 4 milligrams, IV or IM, is the preferred analgesic for chest pain. The reason why it's the preferred analgesic is because morphine has vasodilation properties. If you give morphine to a patient that is having chest pain, and why analgesics work so well with patients with chest pain is because it actually reduces the amount of work or the amount of effort. Heart's trying to work to stay alive, right? It's dying. So by giving somebody an analgesic, you actually take the edge off and it makes their heart work less. Okay, it reduces oxygen demand. That's what we call it. Reducing oxygen demand is a good thing. Reducing preload, good thing, right? As long as the patient's blood pressure is fine, we're good. We're good to use morphine. We're good to use nitroglycerin as long as these blood pressures are good. But that is how we treat chest pain. We treat it first with aspirin, then we give nitro. If my patient still has pain after my first spray of nitro, let's say my patient's pain level was at an 8 when we started, I gave my aspirin. Believe it or not, aspirin's not going to make somebody's pain go lower, right? It's just reducing the amount of clotting that happens to hopefully don't make the clot worse. Then once we start giving the nitro and that starts opening up those coronary arteries, that's when their pain should start to reduce. Because remember, what did I tell you is causing the pain? Lack of oxygen. If we can get more oxygenated blood into the heart, the pain will go away. So by giving nitro, the pain should start subsiding. If we start giving that nitro and the patient still has pain, that is then when we will give analgesics. Preferably morphine if you have it. If you don't, can we use other analgesics? Absolutely. Something like fentanyl. Definitely a good medication that you can utilize to reduce the patient's pain. Remember, even though fentanyl is not going to really affect the patient's blood pressure or cause vasodilation, it will take the edge off of that patient and reduce the pain and maybe their anxiety, right? So it's a good thing. All right, Alex says, do we have to max out on nitro before switching to pain management with an analgesic? No. Okay, as a paramedic, we can give a spray of nitro. Remember, now we're waiting 3 minutes, right? If my patient's pain's a 10, I'm not going to give them like a spray of nitro and I'm going to be like, come on, 1. Come on, go down to 0, right? I'm not expecting the patient to go from a 10 to a 0 with 1 spray. So typically we'll start a line. I do not want to give my nitrates without obtaining an IV because God forbid we give that patient a spray of nitro and then they bottom out. Now we're trying to fish for a line. It'd be a problem. So I'm going to get my IV. I'm going to give them the nitro. And if my patient's pain is severe, I'm going to start with an analgesic. Right after giving my nitrates, I'll start with an analgesic. If I'm starting with morphine, I'll start with 2 milligrams of morphine on board. We're going to wait. After my 3 minutes, hey, what's your pain scale now? Oh, it's a 4. Guess what? They're getting another dose, right? I'll give them another spray. Wait a couple minutes. If the pain gets worse or the pain isn't getting any better, I might consider giving them another 2 of morphine, or I might just attempt my last spray of nitro, see if that fixes it. And if it doesn't, then I'm going to back it up with more morphine. Our goal is to get the pain to a 0. That is ultimately the goal. Chest pain treatment. We talked about how we're treating it. What's the hospital going to do? Can they give fibrinolytics? Sure they can. Ultimately, this patient needs something called a stent. Now, a stent is also known as PCI. PCI is percutaneous coronary intervention. I would write that down. It must be done in a hospital setting within 90 minutes from door to balloon. What that means is as soon as that patient passes through the threshold into the hospital, they have a time limit in which the hospital must put a stent into that person's heart. 90 minutes for the United States. That's a national standard. This is exactly why this slide, why we check 12 leads in the field and why we need to take the patient to the right hospital and why we need to tell the hospital what we have. We send them our 12 leads. We tell them, hey, we have a cardiac alert, we have a STEMI alert, and they prep the cath lab to perform a PCI. What's wild is if you see over here on the left, side there, that picture of what looks like fishing wire or that little guide wire, what it is, it literally looks like fishing line. And that they pass it through the patient's, they usually go around the groin area. They basically fish this wire up into the patient's heart. They're using ultrasound to figure out where that guide wire is at, and they try to feed it into whichever artery is blocked. Now, they don't just look at a 12 lead and they say, oh crap, we have an inferior wall MI, so that means we have to go to the RCA. No, so what they'll do, they'll look at the 12 lead to determine, hey man, there's a block, we're suspecting it to be in this location. Then they're going to put a dye into the patient's IV. They can visually see with their instruments where the blockage is. So they're able to watch it on a screen. While they're watching it on the screen, they see exactly which artery is blocked and where it's blocked within the artery. That's when they're able to do the PCI, push that guide wire exactly where it needs to be. They put this mesh, which you see here on that photo, over to where that clot is, and then they inflate the tip of that mesh. It's like a balloon on the tip of it. The balloon opens up and it leaves a metal mesh that keeps it wide open. And once they do that, they're able to either dislodge or they'll suck out whatever that clot is to remove it from the patient's body. Okay, and typically when they do that, they're going to remonitor, still using the dye. Do we have good blood flow? And if they have another clot, they'll go and put another stent. So typically if you hear somebody say, yeah, I had 2 or 3 stents put in, they had multiple clots or multiple blockages. And that's exactly what PCI is. Must be done within 90 minutes from door to balloon. Right ventricular infarction. If my patient has an inferior wall STEMI, I know, again, this is not me doing an EKG talk, but if my patient has a STEMI in my inferior leads, 2, 3, and AVF, we need to check for right-sided involvement. If my patient has right-sided involvement, this is known as a right ventricular infarct. Right side involvement, also known as a right ventricular infarct. What changes in our treatment? So Chris is 100% right. For us to check for that right ventricular infarct, we need to move V4R, right? Or our lead V4 into the right side. Okay, no nitrates gets brought up. Why no nitrates? Because remember, deoxygenated blood gets brought to my right side of my heart. The right side of my heart is where blood enters. That's where my preload is, right? My preload starts on the right side of my heart. If I give nitrates to a patient that has a problem with the right side of their heart, a problem with their preload, nitrates lowers preload. So if I already have a problem with the right side of my heart, I'm going to have a decrease in preload. And then if I give them nitrates, it worsens the preload, even though it's already bad. Okay, these patients are very right side dependent on their heart. The right side of their heart needs help. By me giving nitrates to a patient that has right-sided heart failure or right-sided ventricular infarction, I can cause a decrease in cardiac output, ultimately even killing the person and bottoming out their blood pressure. Okay, this is why we do not give nitrates to a patient with right-sided involvement. What changes our treatment? Obviously, we don't give the nitrates. Instead, we give IV fluids. We must give these patients IV fluids. Okay, we could start with a bolus of 500. Our goal is to maintain, again, preload. That is our goal with these patients. Maintain preload. Now, what if I can maintain preload by giving pressors? What do you guys think about that? What if I gave that patient like dopamine, or I gave them epinephrine infusion to increase contractility and increase rate? Do you think that's a good or a bad thing to maintain perfusion or maintain a preload inside of that heart? Do you think by me giving a pressor, would that be a good or would that be a bad thing? Palermo says it'll make them die faster. And he's right. If the patient's heart is already dying and it has a lack of oxygen, and then you give them a medication that's going to make their heart work harder, it's just going to die faster. Okay. Ultimately, we do not want to make this heart do more work. We want to help this heart by just giving it more volume. Okay. Again, we increase preload when patients have right side infarction. How will this patient present? This patient will present with a decrease in cardiac output. So we talk about cool pale diaphoretic in patients with shock, right? We talked a little bit about cool pale diaphoretic in patients with ACS. These patients will not only look cool pale diaphoretic, but their blood pressure will also be aligned with that look, right? Typically, just because you have somebody with chest pain doesn't mean they're going to have a low blood pressure. But if you do have a patient that has a low blood pressure and your patient looks not good, right? They look very pale, mottled, whatever the case might be. These patients that have right ventricular infarction, they present like that. Okay. It's not uncommon to see a patient that looks like they are literally in shock. And then you put on a blood pressure cuff and you see that they have a low blood pressure. Then you find out that they have right side MI. We should never be giving these patients nitro. A lot of contraindications there, just blood pressure alone, right? Here's an interesting one. Takotsubo Cardiomyopathy. What this is, it's called broken heart syndrome. I know, sounds strange. It's a heart attack caused by emotional stress. You see this in somebody who lost a loved one. So somebody whose heart's broken, so distressed, they're so stressed out by their loss, they're so sad that literally it causes a heart attack. You might say, what the hell? What the hell is Takotsubo? This little diagram in B is a really old Japanese trap used to trap octopus. Okay, it's called a Takotsubo. Now, if you look in A shows the left ventricle of a patient's heart. And look at the shape of the left ventricle. Look what happens to the left ventricle. The top of it goes like this, closer to the atrium. And when you look at the actual apex of the heart, it gets really wide. So what happens to the ventricle or to the chamber of the ventricle, it gets like enlarged with Takotsubo. I'm guessing just because of the enlargement of that chamber, it puts pressure on the outer walls of the heart, limiting the amount of blood that's getting into the coronary vessels. And these patients die of a heart attack just from emotional stress. Takotsubo. Pericarditis. Viral, which is most common. Bacterial or fungal infections that literally will cause a dysrhythmia in your heart and chest pain. So literally the pericardium that surrounds your heart becomes inflamed. Pericarditis. Pretty obvious, right? Now, the interesting part about this chest pain is it's not fixed with nitro. Since that heart's becoming inflamed, it is technically a lack of blood flow that's getting to the heart. But by treating the patient with just NSAIDs, non-steroidal anti-inflammatories, you can actually reduce some of the pain that this patient's experiencing. Also, by positioning, having that patient with pericarditis lean forward reduces pain. Okay, don't have them lay back on your stretcher, sit them up and make them lean forward. Now, typically with pericarditis, how we'll know is on a 12-lead EKG, we'll have a lot of ST segment elevation. And remember, concave versus convex. If they have a concave appearance within their EKG ST segment elevations, that is typically seen in early repolarization and in pericarditis. So that is typically how it's given away. Massive ST segment elevation in multiple leads, and it's in a concave shape. Viral pericarditis resolves on its own. Bacterial pericarditis must be treated with antibiotics, and fungal pericarditis is treated with antifungal medications. Now, obviously, these patients are going to require blood work to determine if they have a viral, bacterial, or fungal infection. So there's nothing you're going to do as a paramedic to be like, this is probably viral. Yeah, you have no idea.